Thank you, Dr. Haywood. And hello, everybody. It's an honor for me to have the pleasure of leading us into the close of our Mullen Institute this afternoon, really with an invitation for actionable next steps. But on behalf of the Beyond Flexner Alliance and the Mullen Institute, I'd like to thank all of the panelists, the moderators, and the attendees, as well as all of the Mullen Institute staff working behind the scenes. You all have done an incredible job. And this has been a fantastic summit. The two main goals of today that Dr. Pittman had mentioned were to identify institutional and structural factors in the continuum of health professions education that hinder racial equity, and also to articulate a comprehensive strategy that engages a broad base of actors in the effort to deconstruct these factors. So for the last 20 minutes of this excellent summit, what I'd like to ask that you all do is for you to send in your takeaways and thoughts into the Q&A box. And what we'd like to know is what you think we as a community should do next to move the agenda to reduce structural barriers. And also, what are your recommendations for how we move forward collectively? Today, we have unpacked structural barriers to racial equity in health professions and health professions education. From curriculum to culture, our panelists have presented the challenges that some of these educational pathways have encountered in diversifying the health professions, from nursing to public health, medicine, and beyond. And I specifically mentioned beyond because, as Dr. Pittman also had mentioned in her intro, she referenced the continuum of education and potential interventions beginning far ahead of when students actually reach us in their graduate health profession programs, which was echoed by Dr. Romero Leggett in the work that she's doing in New Mexico, which was echoed by Dr. Talamantes, while also mentioning, the cost barrier for many potential students of color. We also heard about the challenges that are related to changing the experience of students and of faculty of color once they actually are in these spaces. Lash Nolan had mentioned underrepresented minority students often not having access to clinical shadowing experiences because those aren't part of their peripheral lived experiences or part of their close, tight networks. Dr. Rankin had mentioned bias neutral admissions and the need for faculty development tools in order to reform the institutional processes. So identifying these experiences are really particularly important because diversity without also addressing that inclusion piece can be really superficial and is obviously also unsustainable. And to the point that I believe Dr. Rock and Dr. Bacho were actually just making, it's also not socially accountable practice. Also mentioned by Dr. Rock that I want to point out, diversity and inclusion should be shared responsibility, and institutions should be evaluated on these measures. So I appreciate Dr. Rock, Dr. Portela Martinez, and Dr. Bacho for pointing that piece out. So moving forward, we really have heard today a lot of multiple examples of theories of change being successfully moved into practice. These have included promoting mentorship programs as practical measures, and really around a few different areas that we'd like to expand on as we move forward. There was a couple of pieces that have stuck out to me, and in a moment I'm going to ask for a couple of my moderator colleagues to also chime in with a couple of their quick summaries. But there seemed to be some consensus or at least some shared values around articulation, in which Dr. Carter had mentioned the development of bridge programs with historically Black colleges and the need for engaging community stakeholders as part of that process. There was also some discussion around funding as a potential lever that I'd like for folks to explore and keep in mind as we look, for example, at the work that Dr. Romero Leggett had mentioned in HRSA, funding regional hub infrastructure that supports academic medical centers being involved in interventions far earlier than the university, really a true K through 20 intervention pipeline that integrates community engagement. We also spoke a little bit about regulations, and I believe Dr. Soto Green had mentioned giving examples of structural racism and social justice curriculum framework that was offered. And if there's opportunities for that as a next step point, as well as Dr. Rocks mentioned recently about the accreditation the need for accreditation to recognize equity as being part of their process. What are the next steps beyond that curriculum portion of it? And to paraphrase Dr. Batra, how do we capitalize on both the governmental and the non-governmental movements and promote metrics that are related to community engagement that are formally recognized? So as we sort of move on that, I would like to quickly just ask if I could call on our panel moderators to share a quick synopsis, no more than 3 minutes, of their key panel takeaways that might practically guide a policy and research action agenda. And I'll start with Dr. Stryker, if he's still on.
Thank you. So from our panel, and you did a great job summarizing the issues that came up across panels. So I think that was really good. So thank you. As we look across the panel that looked at educational pathways, what we saw were people who talked about their programs and obviously their policies that they embedded within their programs to make those kind of changes, whether it was policies in the admissions committee that Dr. Rankin talked about, that specifically looked at both creating an atmosphere and some specific tasks for the admissions committee to do, whether it was around implicit bias and holistic admissions. And so that's a process that can be adopted across, or it was even the bridge programs of that Dr. Carter, and also if you can look at Dr. Carter and Dr. Romero-Leggett's programs as bridging across from K all the way up to wherever it is in the graduate health professions programs. And one, it was about creating links with other institutions that have diverse populations. And Dr. Carter talked about HBCUs, and there are a lot more HBCUs. She didn't take over all of the HBCUs in the United States. And then, but there are also Hispanic serving institutions, and there are Native American serving institutions. And then we look at the meticulous areas of addressing from K to elementary, middle school, high school, college area that Dr. Romero-Leggett talk about. So it's important that we have to see this as a continuum, see that our sphere is bigger than the sphere that we actually operate in. Dr. Telemontes talked about not just him working at the clinic situation that he works in, but they reach out to get people to actually become clinicians down the road. And actually, if you look at the first community health centers in the country, which was in Mount Bayou, they actually, that first community health center created a number of health professionals that came out of that experience back in the civil rights era. So I'm saying all this to say that our sphere is bigger than we think it is. So you might think you're in a PA program or a medical school or a nursing school, but you have to look beyond there. But the sphere that you're in, just being in those spheres, is a point of privilege. And that point of privilege allows us to challenge the systems that are currently in place and to disrupt them in a way that we can move toward equity.
Thank you, Dr. Stryker. And Dr. Haywood, if you wouldn't mind adding a quick 2-minute synopsis of potential actionable levers that we might be able to.
I'd be happy to. So I think during our panel, what we heard was that policy is really a fertile ground for the creation of what I'll describe as durable and systematic change. But it's also a challenging ground. And as stakeholders, we really have to continue to advance the call to dismantle racism and other forms of oppression. And I think we heard 3 great examples from our panelists. One, we talked a bit about institutional policy, and Dr. Rock used the idea of the minority tax as an example of an institutional policy that we need to look at and figure out how do we turn this minority tax into our benefit? How do we turn that into a benefit? And there can be policy around that. Secondly, we heard from Dr. Batra about leveraging accrediting bodies to institute policy change and how we might extend the work that these accrediting bodies have done so that it is actually more forceful in terms of how we think about change. And then finally, we heard from our last panelist about how we use private and public organizations to create transparency. I loved the work that is going on with the tracker, because that will create transparency. And where we have transparency, racism and inequity cannot hide. And I love that. So I think as we begin to expose these issues using good data and good methodology for bringing it out into the open, I think that change is inevitable.
Thank you so much, Dr. Haywood, and thank you, Dr. Stryker, both for just excellent wrap-ups to some very practical, tangible agenda items that came out of the last couple of hours. It's very much appreciated. As we kind of close up here, our focus now really is, what needs to be prioritized in order for these practice examples that we've heard all throughout the day to really guide policy objectives and research objectives that can address structural racism. And furthermore, as we look to inform a policy action plan to dismantle structural racism in health professions education, I also ask for you all to kind of reflect on where you see yourself in this process. And also to you, what does the continuation of today look like? So as we give some thought to those next steps, I'd like to just quickly check in on the chat box with our last couple of minutes here.
Hi, Toyeshe, it's Candace Chen, and I have the honor of giving voice to some of the questions and the comments that came in through the chat box. And I have to say that the comments are really rolling in. There's some really interesting ideas here that I'm going to share with, because not everybody can see them. And I think it is, what it suggests to me is that this is just a start in the conversation. And so I am not going to get near all of the comments, but I think a couple of comments that have been really interesting and have brought up some interesting ideas. Unfortunately, some of them are coming as anonymous. So if this is your idea and you want to contact us and take credit for it, please do. We want to hear more from you. One person, an anonymous submission, wrote, "One strategy worth further pursuing is advocating for adoption and implementation by healthcare organizations and educational institutions of the Commonwealth Fund's Charter on Professionalism for Healthcare Organizations." And I looked up the Commonwealth Fund's Charter, and it addresses issues of patient partnerships, organizational culture, community partnerships, and operations and business practices. And I have to say that idea very much reminded me of Lash Nolan's comment that if you're going to talk about it, you need to be about it. And that health professions education occurs in health systems. And so this is an area that I think that there is where we should be paying attention. I think it might have been the same person who also put in this idea: should diverse patient, family, community advisory councils be created at all health profession schools to help inform and transform our educational curricula and learning experiences? And he asks, she asks, what are the pros and cons of that? So I think that it's a really interesting idea. It sounds a lot actually like the community health centers model, which is arguably a very successful model in the US healthcare systems. Another anonymous comment points out issues of intersectionality and going beyond racial ethnic issues to include LGBTQ, disability, language, religion, etc. So also important things to think about. And maybe I'll do two more. Bill McDade, who I happen to recognize is from the ACGME, referred us to the new ACGME requirements, which say programs must engage in practices that focus on a mission-driven, ongoing, systematic recruitment and retention of a diverse workforce of residents, fellows, faculty, senior administrative GME staff, and other relevant members of its academic community. The intent is to drive an agenda of increasing workforce diversity and provision of an inclusive medical education learning environment. He noted that it was enacted in July of 2019 and they're in their first year. I do have to note, it reminded me a little bit of when Efrain Telemontes was talking about challenging the status quo, but then also testing whether changes did what we thought that they would do. And I know Sonal Batra highlighted the work by Dow and Boatwright looking at the effects of the LCME, which was an incredibly important, I think, piece of work. And Dow and Boatwright is arguably a leader in this, a lead researcher in this area. But I will note that while it changed the directionality of diversity, matriculants who identified as Black only went from 6.8% to 7.3% in that study. And then the final one that I'll do today is from Monica Lifson, who these days is here at GW, leading as a leader in our internal medicine department, but I know came from Veterans Affairs, and so brings a very kind of high level thinking. And she says, consider the competencies that Dr. Soto put forth that all can potentially adopt and use across platforms. Similar to IPEC, which is the Interprofessional Education Collaborative, as Dr. Batra mentions, convene all health professions in the area of structural racism. And she comes up with a number of additional ideas, including partnering with our communities to move institutions to demand and demonstrate a workforce that reflects the community, and a couple more as well. I think that there are still things rolling in, and we will capture these and work through them and make them available after the summit.
Absolutely. Thank you so much, Dr. Chen. And just to leave sort of finally on a couple of thoughts for further consideration. Again, as we really think about the policy priorities to push and what a research agenda that would strengthen that case looks like. I do just want to quickly point to a quick quote that really resonated with me that our moderator, Dr. Ward, had mentioned earlier, which is what's the blueprint to an anti-racist society? We've never seen it. And I leave us with that one because of the fact that I think another question had come into the chat box earlier in the day, which was really asking from the audience about, how is it that we can determine benchmarks for success? And I think that the final panel of today really kind of asked a lot of that question. And I think that's part of where some of our driving questions really do need to move towards. So thank you all for those contributions. I would like to thank you all again and let you all know that we will be creating more planning spaces, beginning with a survey tomorrow to generate your ideas, give you an opportunity to digest some of today's thoughts, but also soon enough to be able to still collect your ideas while they're still fresh. As Dr. Chen mentioned, we definitely want to make sure that all those pieces are included as we move from the general to the specific priorities for change. Thank you all again, and I'd like to pass it on to Director Pittman.
Thanks, Toyosi, and I couldn't agree more with this idea of sort of the absence of the blueprint. I think all of this has been terrific input for us at the Mullen Institute, both to rethink what we're currently doing and to imagine new areas of work. But more importantly, we actually would like to think about how our work fits into a bigger picture. So as Toyosi said, we will be sending out this survey. We'd like to reconvene a smaller group of those of you who are willing to continue to work with us in this area. And the idea is that we would perhaps in the second week of December, after you had time to read our report and to provide input via the survey, to really, I don't know if blueprint's the right word, that's very ambitious, but certainly to create sort of a plan of action that includes many different organizations and individuals from many different walks of life, anyone who essentially wants to participate. And the reason for trying to make that plan more explicit and more transparent is precisely so we can begin to understand, well, first of all, to use our resources wisely so we're not falling all over each other and repeating ourselves in ways that are not efficient, but also to begin to construct a shared knowledge base about what works. and shifting this, not just from describing the problem to imagining solutions, but actually evaluating solutions and actually learning from those evaluations about what works. And I think for us, the key is always data and transparency and accountability, but other organizations may be approaching this in different ways. And so it's an interesting conversation to think about how we could evaluate what works in this space. At any rate, we our pledge to you all is that this is not the end, it is the beginning, and we very much look forward to working with you all. We really were blown away by the level of participation. Almost 900 people signed up. We're not always 900 people on at any given time, a phenomenon of the Zoom conference era. But on the other hand, I think the Zoom conference era allowed us to reach out to people across the country who didn't have to pay to participate, didn't have to travel, didn't have to put their health at danger. So we had some advantages there as well. At any rate, thank you all for participating, and we will be in touch.